This would save 10,000 lives per year. Ensure your colleagues across your health systems are advised, educated, supported, and actively working together to make every clinical contact count. To identify undetected heart failure at consultations, look for the 3 common F-word symptoms and consider an NT-proBNP blood test. The earlier heart failure is detected and treated, the better the outcomes and quality of life for the patient. There are posters that can be easily downloaded and printed from the BSH website, which you can display in your clinic settings, and infographics available in different languages that you can use for your patients. We will kickstart Heart Failure Awareness Week off with a superb webinar this evening. We have a packed agenda. I would like to introduce our first speaker this evening, Chanel Opoko Achampong, a clinical pharmacist, and Caroline Wick, a heart failure clinical lead nurse for North Middlesex University NHS Trust, and a member of the BSH Nurse Forum, who will present on the project going on in Enfield's eastern deprived neighbourhoods in the identification, management and interventions for adults at risk of developing or with heart failure. Thank you both.
Thanks, Delith. Chanel, you're going to put the slides up. Thank you. So thank you for the opportunity to share with you our Heart Failure Health Inequalities project, which involves encouraging and supporting people at risk of heart failure to adopt healthier lifestyles. We identify and diagnose and support people to better manage their heart failure. And we're connecting to resources in the community, for example, the voluntary sector, and improving heart failure education and training. We fortunately obtained funding from the North Central London ICB to target patients living within deprived areas of Enfield. That's the eastern neighbourhoods. And if you know this area, it's sort of Edmonton up to Ponders End area. We've got a number of objectives of the project, but this evening we would like to share how we are detecting patients on GP registers. At the start of the project, we were unable to recruit heart failure nurse specialists, and therefore we reached out to the GP Federation and obtained help from the clinical pharmacist, which has been really essential in enabling triaging and managing patients on the GP QOF lists. The collaboration has been really successful, and I'm going to hand over to Chanel now, who's one of our pharmacists working on the project, to explain more. Over to you, Chanel.
Thank you, Caroline. So just looking at the data within and around 2,300 people have been diagnosed and living with heart failure in Enfield, according to the data provided by BHF. However, according to QOF guidance and prevalence rates, there should be approximately 3,000 patients that actually do have heart failure, meaning that there are approximately hundreds of people living undiagnosed. So the role of clinical pharmacists within this project. So the role is twofold within this project. So we help to detect patients and aim to increase our QOF heart failure list by approximately 10% to meet the 0.9% QOF prevalence figures. We aim to do this by primarily clarifying diagnosis of patients with heart failure, suspected heart failure, raised NT-proBNP values, and abnormal echoes as well. We also ensure appropriate coding of patients already on the register. So whether that's with heart failure with reduced ejection fraction, mildly reduced ejection fraction, or patients with preserved ejection fraction. In addition to this, we are also the main point of contact for medication queries. So we're helping to improve the quality of reviews and also optimizing heart failure therapy. Looking at reducing risk of cardiovascular disease by also looking at blood pressure management and lipid management. So making every contact count. We're encouraging and supporting patients to make healthier lifestyle choices, and also empowering them to take care of themselves and manage their own self-care. We're also helping to improve patient quality of life by optimizing their medication and looking at their NYHA classification to help measure their functional class, as well as looking at the KCCQ, which is the Kansas City Cardiomyopathy Questionnaire, to quantify changes to quality of life. In addition to this, we are also in charge of kind of supporting with complex cases and managing and encouraging proactive care planning and personalized care. So this is the Ardens case finder list. I'm not sure if anyone else is aware of this list within their area, but what we use it for is to help identify patients. We found it very useful within our area. So it's been used to increase prevalence by identifying patients with heart failure who have not already been added to the register, or patients who have heart failure but do not have any LV function assessment coded. So as seen here, you can see that it also generates reports of patients who have, for example, been coded with an ejection fraction of less than 45%, or patients with a raised NT-proBNP greater than 400 but do not have any echoes coded. So it helps us prioritize patients that can potentially require urgent specialist review. So another resource that we've also found useful is also this one made by the UCL Partners Framework. So this project has actually been ongoing for about a year now, and this framework was published a few months ago. So it's for the management of heart failure within primary care. It's a great resource and it's available online, so we can share the link later on in the chat box. So this slide from the framework focuses on desktop reviews to aid appropriate coding and perfectly summarizes the work that we've already been doing. So we start off by looking at patients already on the heart failure register, and if they've not been coded as HFrEF, HFmrEF, or HFpEF, we review their diagnosis, looking at their echoes, NT-proBNP values, symptoms, and then we discuss this at our heart failure multiple disciplinary meeting. So we always need to ensure that patients have their heart failure type coded accurately, as this is essential for allowing for targeted management at an earlier stage of disease and avoidance of non-evidence-based therapy, especially in patients with HFpEF. Too far. So this slide just looks at a more detailed guide to completing desktop reviews and how to prioritize patients for early review. In addition to this, we also have searches which help us look at patients' previous NYHA classes, so thereby allowing us to prioritize patients who, for example, were last seen, when they were last seen, they were NYHA class 4, so we can look at those patients first, for example. So it's important to note that it is advised to keep patients with a historical ejection fraction of less than 40% coded as heart failure with reduced ejection fraction, even if the ejection fraction has improved following optimization of the 4-pillar therapy as per the European Society of Cardiology. So just making sure that they're still kept on that register, so that they're kept on the medication, so that the patients don't then decompensate. So we're just going to have a quick look at a patient case study. If it can let me. Oh, sorry, just having some technical difficulties here. So, sorry. So this patient was identified using the Ardens case finder list, and they weren't previously on the heart failure register. So they appeared on the list because they had a previous echo code of left ventricular diastolic dysfunction from 2012, but they weren't on the heart failure register. So the patient was then brought in for a review of their symptoms, and we found that they had increased shortness of breath. They also had some paroxysmal nocturnal dyspnea and also ankle edema. At this point, they were taking furosemide PRN. So their last NT-proBNP, was 353 from about a year ago. So we had a repeat NT-proBNP and also a repeat renal function test. And the NT-proBNP came back at 2,925. So it was a significant increase within the past year. So this patient was then discussed at the heart failure MDT, where we were then able to refer the patient and expedite their appointment to the Rapid Access Heart Failure Clinic with Dr. Roger Rear, where they would then get a same-day echo and also consultant review on the same day. So in terms of the benefits of this project, we've been able to engage with the wider workforce. So our MDT, for example, consists of the local consultant cardiologists, community specialists, heart failure nurses, and pharmacists. So during our MDTs, we're able to clarify patient diagnosis, optimize heart failure medication, and also refer onwards for specialist care, thereby greatly improving patient outcomes. We've also been able to increase prevalence. In the last financial year, for example, within 2 GP surgeries, we've been able to increase prevalence by 19.3% and also by 16.7% in another surgery. We've also been able to identify patients with unclear or mixed diagnosis. So by adding them to the heart failure register to ensure that they receive appropriate management whilst also decoding patients who weren't previously coded correctly onto the register. We've also been able to provide support for GPs, so by helping manage GP workflow and releasing capacity, improving patient quality of life. So through annual reviews, assessment of symptoms and optimization of their medicines, patients have reported that their symptoms and daily functioning has improved. And we've also been able to report a reduction in NYHA classes, demonstrating the quality of the reviews and the interventions that we have also made. In addition to this, we're trying to support people at risk of developing heart failure or people who already have heart failure to adopt healthier lifestyles. So referring them onwards to cardiac rehab or smoking cessation. And we're also aiming to upscale our team members, so delivering teaching sessions and providing updates regarding diagnosis, treatment, and management. So looking ahead, what we're aiming to do is enhance the quality of our patient reviews. Also build onto existing resources and strategies, improving education and training, not just for patients, but also for team members as well, and healthcare, other healthcare professionals, looking at our admin teams, for example, and improving their education around coding patients appropriately from discharge summaries or clinic letters. And then also trying to provide education on symptom recognition and reporting to people diagnosed with heart failure and their care providers, as well as raising awareness in the community as well. Thank you very much for having me this evening.
Oh, fantastic. Thank you, Chanel and Caroline, for that wonderful presentation on what's going on in Enfield. There will be an opportunity in the panel discussion. So if you have any questions for any of our speakers, then please do put them in the chat and we will try and address as many as we can during the panel discussion. So I'd like to introduce you to our second speaker, Joanne Brown, who's an advanced paramedic practitioner with 20+ years experience in unscheduled and emergency care, and is now clinical lead for the National Cellulitis Improvement Programme and lymphedema screening in heart failure, and is going to talk to us about the collaboration going on in Wales. Thank you, Jo.
Thanks ever so much, Delith. It's lovely to see you all in such a wide range audience as well. So thank you ever so much for the invite. I'm just going to pop my presentation on the screen there. Right, okay. Can you all see my screen? Perfect. Okay. Well, as I said, thank you very much, Delith. I wanted to talk to you a little bit about Lymphedema Wales and the collaborative work that we've been doing with the heart failure services around Wales. Some really exciting projects in the pipeline with some really interesting results that are starting to come out. So why heart failure? Why lymphedema and heart failure? Well, we know within the lymphedema services that there are around 60% of people with heart failure who have chronic leg edema. So what this means is that it's one of the key signs for heart failure. But from a lymphedema perspective, we also know that that carries its own risks as well. We know people with lymphedema are more likely to fall. They're more likely to develop a bacterial condition called cellulitis. They're more likely to develop leg ulcers, and these can be really tricky to treat in patients with lymphedema, with long-standing chronic edema. And patients tend to report poorer health outcomes as well. So talking about detecting the undetected, for us, this is super important that we start to find these patients with heart failure who have this chronic edema. We know that after 3 months of having lymphedema, we know it doesn't respond very well to diuretics, and that's because the lymph fluid is starting to solidify, and it's really difficult for the kidneys to work on this kind of fluid. So we know the consequences of not being able to treat lymphedema acutely, effectively, and responsibly can have deteriorating health results in these patients, and lots of wasted economic spend on unnecessary ulcers, falls, the ambulance service involvement in falls, and the calls out to these patients. So moving on, how did we do this? So with the lymphedema service, we approached the heart failure services with a very simple approach, really. And that was to come into the heart failure services to look at the patients that you were seeing in your clinics and to do a joint assessment. We're aware that it was very much a heart failure assessment, but from a lymphedema perspective, we could see lots of things that we could help with. So part of it was to provide some intervention and then to review those patients in our own lymphedema clinics about a month to 2 months later. So some of the examples of the patients that we were seeing in these clinics. So with patient A, this was a follow-up heart failure clinic where this patient was already started on those 4 pillars of care in order to control their heart failure symptoms. But whilst we were there, we were able to give really good advice about skin care. We were able to provide those compression garments that are the key to removing some of that extra fluid, along with diuretic titration, fluid intake advice, etc. And what we found is that edema was starting to resolve quicker, skin care was starting to really improve. This patient then developed more stable heart failure symptoms because of the input from both services. And this patient just needed a GP referral for those garments. Now, most of these patients only require what we call a circular knit, a mild class 1 circular knit. These are around £10 to purchase. So for the sake of £20 per year, a patient having 2 garments once a year or twice a year possibly, we could really, the economics of reducing edema versus not controlling that edema and the ongoing cellulitis risks, skincare problems, etc. It really made economic sense. So there's some more examples there, but I'm aware of time, so look at those at your leisure if you wish. So some of the headline news that we found, particularly from Swansea Bay. Now I'm due to present some of these results tomorrow to Swansea Bay, so I've just got the headlines news at the moment. So as I said, most of these patients had mild edema. This is really simple, really easy to deal with, but the economic consequences and the health consequences for the patients in dealing with it in that mild stage are really huge. Around half the patients, all heart failure patients have lymphedema in some form. As I said, most are mild. Only a very small number are known to the lymphedema services. So I can tell you that's about 9% of the patients who had lymphedema within the heart failure services were actually known. So to us, that's a real unmet need there. That's really all about detecting the undetected for us there. Interestingly, there wasn't one particular heart failure type that was more susceptible to lymphedema than another. So everything from a HFrEF to a HFpEF all carried an increased risk of lymphedema. Cellulitis was something that many of the patients had experienced, and all had had lymphedema as a contributory factor. And the quality of life scores were generally lower for those with edema compared to those without. So already from those early starting figures, we could see that there's a real unmet need here, something that we could really work from in our lymphedema perspective to try and make quality of life better for patients with heart failure. So I've got an example of a patient who we saw as part of that pathway. Now, this is quite an extreme case, but I think it really highlights the good that came from this collaborative work, and particularly for this patient. So she was a 56-year-old female who was seen as a new patient in a heart failure clinic. She had heart failure overload and concurrent cellulitis to the left leg. So she was really unwell. She was actually an inpatient in hospital. She was receiving both IV diuretics and IV antibiotics, but she was known to the lymphedema services but unable to wear the compression because the edema had increased so much from heart failure. Interestingly, she wasn't receiving any wound care at all within the hospital setting. And I think we do something called LYMPRON, which is like a patient reported outcome measure. So patients get to tell us about how they're experiencing their symptoms. I think the most telling one here was this patient said, "I didn't want to live." And that was at the time of that first contact between the heart failure service and the lymphedema services. We knew we had to act. So what we did, we were monitoring this patient really closely within the hospital. Thanks to those really good heart failure services, they hydrated the IV diuretics, and this patient actually reportedly lost 5 stones in fluid over the coming weeks. we were able to come in from our perspective as well, from a lymphedema perspective, and we visited this patient in hospital. And as a result of those visits, we were able to refer the patient to the tissue viability nurses. We gave bandaging education to those ward nurses who were really quite worried about bandaging legs with a patient with heart failure. We were able then, that once she had been offloaded, we could fit her with compression garments, and we could give some really good leg care education to that patient. The bottom right hand picture just shows a picture of her legs after they'd recovered. She did so well because of this collaboration. It was really quite incredible, and I think it's something that we should all involved with this collaboration feel really proud of. Now, one of the ways in which we're trying to look at that, detecting the undetected, is about education amongst healthcare professionals. Now, unfortunately, this survey has just closed, but what this survey was about was discovering the gaps in the knowledge between the two areas. So what do lymphedema therapists know about heart failure? And what do heart failure clinicians know about lymphedema? And where's that education gap? Is there something that we can do where we can plug that gap for all people involved, so that both conditions can be treated promptly and effectively? What we do know is that we've had overwhelming response to this survey from the 4 nations. I think there's been about 350 responses. So these results are yet to be analysed and published, but watch this space because I think it's going to be a really interesting read. So I think that's the end of my presentation there, and I think you're doing questions at the end. Is that right, Dennis?
Yes, it is. Thank you, Joe. I think, we've just had a bit of a sneak peek to some data you're going to be presented tomorrow. I think we're very lucky.
Yeah.
But, to me, we're looking at the, 2 services come in to work together collaboratively. And I do wonder that in years to come, we'll look back and think, how did we ever do it any differently?
Yeah.
Thank you so much.
It's an absolute eye-opener, but thank you, Delith. Yeah, thank you.
Great. I think you'll have some questions later, Joe. So our next speaker, I'd like to introduce Louise Brady, who's the primary care nurse lead for NHS England, who's going to be talking about what's going on with heart failure in primary care. Thank you, Louise. So you're on mute. Oh.
Sorry about that. So evening, everyone. Great to be here. Thank you, Delith, for asking me. My name's Louise. I'm the primary care nurse lead at NHS England, and I'm a practicing general practice nurse. So I wanted to take you on a quick whistle-stop tour, really, of my personal journey into the wonderful world of heart failure and working in collaboration with patients and families. And I've talked about making dreams come true because general practice nurses, I don't know if you all know, but we see 84 million patients per year, consultation wise, and general practice as a whole sees 1.3 million patients each and every day. So it's a wonderful opportunity, as Delith beautifully narrated, to make every contact count. So my focus is on policy, practice and education at NHS England, and obviously optimising and supporting patients living with and beyond heart failure.
You're on mute, Louise.
So a little bit about me. I started my patient journey into the world of heart failure back in 2015, when I started to look at this at my own practice that I'd worked at as a registered nurse for 17 years at the time. And we were seeing a lot of patients being driven into hospital with the signs and symptoms of heart failure. So I reached out to the Pumping Marvellous Foundation, who, as we know today, are very, very well known. And we did a whole piece of work across 10 conurbations in Greater Manchester, looking at raising the profile of heart failure awareness. And we developed toolkits for both primary care and community nurses and for nursing homes, so that we could have a real we could have the foundations really and awareness around heart failure. So that was a really good piece of work. And it was called Marvellous Mentors. So if you have a look on Nick Hartshorne-Evans' website, who's the CEO of Bumping Marvellous, you'll see it on there, and the toolkits are still operational today. And something really important that Nick told me, and he said, you know, Louise, it's really, really difficult working in primary care because we know a lot about a little, we're not specialists, we're generalists. And he says it's very, very difficult. You can't sell failure. And it's how you work in partnership, therapeutic partnership with your patients that makes the difference. So if you want to read about our Greater Manchester outcomes, if you like, it was, as I say, a fairly big piece of work at the time in 2019 and involved generalist specialist nurses in partnership with patients, carers and families. And it was looking at that early detection prevention across a very, very large population and how we de-escalated some of those harms, really. So as I said, this is our NHS digital dashboard, and some months nurses are seeing 6 million patients every month, some months 7 million. That's great. Bringing it up to date, we are delighted to be working with the British Society for Heart Failure, Delith and Poppy, in a collaboration with NHS England. And what we want to do is join together our generalist nurses and our specialist nurses who have that breadth and depth of expertise. And in 2022, NHS England published a core career and capabilities framework for general practice nursing in primary care, working at 6 different levels. So from support work level right up to nurse consultant level practice. And what we have developed is a collaboration on a repository of educational tools, frameworks and resources that have been mapped together by specialist and generalist nurses, and we're hoping to have that published in the autumn, so watch out for that. At one of the surgeries where I work, there is a fantastic nurse called Claire Underwood, who's a general practice nurse, she's on my left, and Caroline Jones, who's a specialist heart failure nurse on the right. And operationally, they work together in a clinic to manage patients with heart failure, to reduce the symptom burden really of living with that disease. And obviously they've been recognised for their wonderful work by the people that count, by our patients. And I'm going to talk a little bit more about that work and the outcomes at a study day that we have with the British Society of Heart Failure that's coming up in June. So if anybody's interested, do please come and hear more about that work in June in Birmingham. So when Delith asked me to come and present tonight, I thought I'd just share some very, very common scenarios, because we have, as general practice nurses, the opportunity. We can be very strategic and go through our registers and use the Ardens case finder list, but often you know, we need to be able as clinicians to use our clinical acumen and actually put the pieces of the jigsaw together. And being a general practice nurse is like being a bit of a detective, really. So this is Joan. Joan is of South Asian origin, lives with type 2 diabetes and COPD. Joan is obese. She tells us that she has the occasional glass of wine with a meal. Her blood pressure is elevated and not controlled, but her heart rate is regular. She tells me that her weight fluctuates and she can't seem to lose any weight despite moderate exercise, and she's definitely tired all the time. She's quite low in mood as well, and that's particularly significant because this has been creeping up in the last couple of months. And she feels that her breathing has deteriorated, and she's been to see her general practitioner 3 visits in the last 6 months, and that was coded as acute exacerbation of her COPD. and she's had rescue steroids and antibiotics. So for me, as a quite an experienced general practice nurse, there's loads of red flags within that scenario. So things that I've read on the GP record around Joan's biometrics, so her ethnicity, the fact that she's obese. So I look back, has she had an NT-proBNP in the past? No, but if she has, the result might not be accurate. Her blood pressure is not to target, so we've got chronic hypertension that she's probably been walking around with for some time. So we're going to get stiff ventricles there. It doesn't look like she's having any chest pain or she's got any AF, but I won't know that till I do an ECG and all the blood tests and a workup for an echo. I'm concerned that she's been given prescriptions for antibiotics and steroids because it may be that she's had an acute exacerbation of her COPD, but it may be the advancing symptoms of heart failure, including the ankle swelling that's causing the issue. So there is so much there alongside her diabetes control that we need to look at and optimize. But the first thing is obviously to do the fundamentals really well. And that is obviously to make sure that we get a rapid, comprehensive holistic assessment. Why I like this comes from the Primary Care Diabetes Society and a brilliant specialist nurse called Jane Diggle. And she talks about 3 key areas for heart failure: timely diagnosis, appropriate referral, and optimal treatment. So if I look at my desktop planner on the left and I look at heart failure signs and symptoms, obviously I can see that Joan's experiencing quite a lot of those symptoms and those signs on physical examination. But I think sometimes as well, it's how we elicit those signs and symptoms within that time-pressured general practice consultation. And I like using some of Jane's questions on the right-hand side. So how are you sleeping at night? What's it like when you sleep flat? Do you have any ankle swelling? What's your body weight been like? What's your appetite been like? And I often ask patients, describe how you think, feel, and what you believe is happening, because that's really useful to get the patient perception. And obviously, this is just a very, very quick desktop guide around taking a detailed history in primary care, including smoking, pack history, alcohol and drug use. It says about obviously taking the ECG and blood tests, and the obvious things are, because she does have type 2 diabetes, a review of her HbA1c, FDC. We're going to check, I would check TFTs as well. And obviously rule out things like anemia when the patient presents with breathlessness. But obviously for heart failure, we need that all essential NT-proBNP with a significant referral so that the patient can be managed. So living with and beyond heart failure. So following the investigations, Joan was diagnosed with HFpEF. It was then really important in primary care that we do put the right code onto either the EMIS or the System 1 coding system into the notes, and I think the Enfield team described that beautifully, so I won't go into all that. But if we do that, then we can understand the etiology behind some of the symptoms. And then, as I say, her specialist heart failure nurse, who works across both community and primary care, comes together with her general practice nurse to support Joan on her diagnosis. And we can't underestimate the shock that patients feel when they hear those 2 words, heart failure. And often they feel like they'll have to go home and something drastic is going to happen. So it's how we support patients with health literacy around that. For us as general practice nurses, we can do a lot in terms of prevention and population health. So around lifestyle, around weight management, around top tips for home monitoring, signs and symptoms of changes in weight. So the 3 Ws, the wake, wee and weigh. Have you got a really good pair of the scales at home that you can use? So we keep an eye on the weight. And we need to make sure that Joan herself has access to the patient-facing support and resources, and the PM team do a great suite of resources in that arena. I think the general practice nurse and the specialist nurse team can develop, in partnership with Joan, a really comprehensive management plan. And the most important things are that we optimise her BP control, her diabetes care, so that we can reduce any symptoms that she may be having. And obviously we want to record everything around exercise and exercise tolerance. And one of the most impatient things for us as primary care nurses is when we think about over time, so a longitudinal time, because living with heart failure, you know, can be challenging on every level. We want to measure patient activation, but we want to be able to do that very quickly within a 20 or 30-minute consultation. So we ask patients how confident are they in managing their own health and well-being. So 1 would be not very able and 4 would be very able. And we know that for every point that patient activation level rises, we can link that to primary and secondary care demand savings of £1,000 per patient per year. And that work is really, really important for us in general practice, and it comes from the National Care Programme that NHS England commissions at the National Association of Primary Care. So thank you very much for listening, and I hope that was useful. And here are my takeaways tonight. So it's timely diagnosis, appropriate referral, and optimal treatment. Thank you very much.
Thank you, Louise. That was a great talk. You really have got to be a detective in your job. The number of patients coming through your doors, but the important access to NT-proBNP is crucial, really, in supporting the diagnosis of heart failure, to be able to prompt and access that echo and the resources for the patient. So thank you very much, Louise. So now we move on to our panel discussion. So now is the opportunity to put those questions in the chat and to ask any of our panelists that have been and presenters involved this evening. But I would also like to introduce you to Anna Briggs, who is a cardiac community specialist nurse from Plymouth and a member of the BSH Nurse Forum, and Tug, who is Anna's patient with heart failure. So please, if you do have any questions for Anna and Tug, please do put them in the chat. And also to Edith Donnelly, who is a heart failure nurse for Southern Health and Social Care Trust in Northern Ireland, and secretary to the BSH Nurse Forum, who will lead the panel discussion. Thank you all.
So, hi everyone, can everyone hear me okay? Yep, getting a thumbs up from Delith, so that's great. So they were 3 fantastic talks. And I suppose the first thing that struck me, 3 talks, 3 different professions coming at heart failure from 3 different directions. But there were definitely some commonalities, which I've really written down, and everybody spoke about partnership. Everybody spoke about collaborative working, and everybody spoke about making every contact count. And I think all of those 3 projects and services that were described really encompass the whole sort of find me, detect the undetected ethos that we're all working towards now. I suppose maybe just if Tug doesn't mind me asking him to start off with, in terms of your own journey, just if there's anything that you would be happy to share in terms of around your own diagnosis, which obviously, you know, you've had your diagnosis now and you've had the care journey supported by Anna and her team. But looking back, can you think of any opportunities when perhaps things could have been picked up slightly earlier, maybe?
I have muted you, Tug. I'm so sorry. You just need to unmute yourself. How rude of me. I just shut my patient up.
I'm there.
Can you hear us now?
Thank you, Edith.
We can.
Yeah, so thinking about my conditions, if I just lay a very brief scenario, we'd moved down to the southwest the year before, and things have been going pretty well. We moved down here to retire, and I suffered a heart attack very suddenly at home, and was rushed into Derriford Hospital in Plymouth, and was given heart attack treatment. They fitted a stent, and they shot my heart back into sinus rhythm. And it was on an echocardiogram following that they revealed that my ejection fraction was down to 10 to 18%. Well, one thinks of percentages in 100% terms, and 10% seemed horrendously low and a great shock. And it was then pointed out to me by the consultants there what my condition was likely to be, what problems I was likely to have, and allowed to go home. So, man, you expect your GP then to pick up on the information and give guidance. I was given good guidance in the hospital, but an awful lot of it is going over your head as a patient when you are first aware of what's going on. You think of the heart attack, but the heart failure aspect is something to most patients, I think, which will be entirely new. And you're uncertain. Everything about you is uncertain. How's your life going to be? And where are you going to be in another 6 months' time with this particular matter? If I continue, the joy for me was I was very swiftly referred to a heart failure nurse and to Anna there. And that made a huge difference at a very early stage, really. I'd already been given the rough guidance, you must take it easy, you must listen to your heart, you've got to take great care about build-ups of fluid and all the rest of it. But the joy of having Anna take over and looking at me on a fairly regular basis was I could ask the questions right there and then, describe some of the strange symptoms that were coming out, and got really good guidance as to how to deal with these things.
Yeah.
And the other great joy, I don't know how much long I need to go on with this, Anna, but the other great joy was to be told, yes, there is an exercise regime that we can put you on that will make a vast difference to you if you can handle it. Well, certainly that was a lifeline to me, along with the medications that were coming my way. Some of them none too easy to deal with. I can remember the warfarin stage as being very awkward and requiring check after check after check. So was very glad when part of my analysis by Anna was I should be moved to something else. And apixaban has worked exceedingly well for me. I don't want to go on too long. I don't want to be accused of rambling, but the point is, I have really had very good support all the way through from a very early stage, and that has made a vast difference.
And I think you mentioned there a lot to talk about the importance of your heart failure nurse.
Yes.
I'll pay you later, Tag.
Yeah. But if I go back to Chanel, and I think you're still on the call, you and Caroline spoke about your project being born out of the fact that there wasn't enough heart failure nurses in your particular area, and Caroline, that you had a problem recruiting heart failure nurses. And I think most of us who are heart failure nurses on the call can probably relate to that. And no matter how well our services are staffed, we could always do with more heart failure nurses, and we're not going to get the amount of heart failure nurses that we want. So I think your project that you described was a great example of not to replace heart failure nurses with something else, but to think a bit more strategically and be a bit, you know, be cleverer about it and think, well, we can't have that full resource. How else can we actually, you know, can we work together with other disciplines? And I just wonder, Janelle, if you would have any advice for any of the rest of us about how to go about, you know, your project sounds great, you know, it sounds like it's very well established, but even a few simple pointers for the rest of us about how, you know, we would go about that sort of collaborative work with GP pharmacists or with the pharmacy profession.
I think just approaching really and kind of just presenting the idea, kind of maybe setting some strategies in place so that everyone knows what the outcomes that they should be expecting, maybe just having some clear guidance so that everyone's on the same page, and then just working together really, being able to be approachable and also asking questions if you have any doubts. I think that's really it, really. I think we've been working quite well together as a team, just working together like that, really.
Yeah, and I think you also said that you were referring into cardiac rehab and those types of other services as well, which again brings us back to Tug. That was the other really important part of his care. And I think, you know, having referral pathways for all their professions, being able to refer into that it is really important. Joanne, again, from the lymphedema perspective, I found that extremely interesting. I know I struggle with that when patients come into clinic. What's the best way forward? And I know that you've done your knowledge gap analysis type thing. When you've analysed the results for that, is there going to be a plan for a sort of a joint sort of upskilling, joint educational type pathway, or what are your sort of thoughts for the outputs of that? I know you're kind of trying to look into the future because you haven't analysed it yet, but you can possibly you might be able to predict what your results might show.
I think, yes, I think it's not hard to see where this is going. Lymphedema therapists, lots of them are physio background. I'm a paramedic background. We've got basic knowledge in heart failure, but certainly not to the level, and sometimes not to the level where we can recognise it easily. So there's lots of kind of potential projects that we're thinking could be born out of this. So, for example, would there be a use for you know, the medical test of proTBNP within a lymphedema service if someone has bilateral edema and those 3 Fs that you talk about that we see? Because quite often we might be the first people seeing those symptoms presenting within our clinic, particularly if they're coming to us saying, well, my edema's getting worse, and it might be a good reason for that. And similarly for heart failure patients, the experience, heart failure specialists, the experience that we've had is when we're talking about the risk of cellulitis, the risk of leg ulcers, and those leg ulcers that are actually coming in and not being managed properly because people aren't aware of them, I think has been a real eye-opener. So we know that there's going to be real gaps. There's lots of literature out there already about heart failure and about lymphedema, so it's not going to be too hard to pull it together to plug those gaps. We just got to know what those gaps are and how we can target this huge audience to get it out there. So we are really looking forward to these results. A little way off, but yeah, watch this space.
And you got one very specific question in the chat here, Joanne, from Joanne Wheatley. Did you see that one?
Yes,
about
I
how
did.
Patients, get referred in as opposed to maybe to your service, perhaps, she's asking.
From the ambulance service as well. It's very, very difficult because like us, ambulance service is Wales-wide, it's pan-Wales. By far the easiest way to refer is via Consultant Connect, which is an app that healthcare professionals have access to, either as a mobile app or as a phone number. We're available as a national service on this number, and any patients that you have that have lymphedema, that are at risk of cellulitis, you can refer very, very easily this way. It takes a couple of minutes. Otherwise, for paramedics, for ambulance technicians, training paramedics, there are many ways you could do this. You could do this via the GP. You could even do it via heart failure service professionals if you have that contact with them. It's very difficult to get all those service names out there to the ambulance service. But quite often the GP tends to be the coordinator of care and possibly the easiest. But if you do have access to Consultant Connect, you can talk to us directly. We'd be happy to take referrals that way, and that goes for everyone.
Okay, thank you, Joanne. And Louise, just very quickly, GP nurses blow me away by the volume of patient contacts they have every day. And I know where I work in Northern Ireland that we do not engage with you to the extent that we should do in the heart failure community. I think we are missing a huge trick. We're missing a huge opportunity. I think individually, probably some of us in our own practice have a friend in certain GP practices that we sort of link into and hook into. But I suppose, again, it's just probably the same sort of question that I had put to Chanel about, coming from a place who doesn't maybe have fabulous established links with our GP nurses. Any hints, tips, tricks about how to start fostering those relationships?
So I reached out to the British Society for Heart Failure and as a strategic lead at NHS England, and we managed to set up 3 round tables where we had heart failure nurse specialists and GPNs round that round table. And we tried to pin down some of the challenges, and obviously on both sides, it's time is the most important currency, isn't it, in terms of the NHS workforce. But we was talking about being able to pick up the phone if you don't know something. In particular, there's a varied practice within the GPN community. So we've got nurses at one level who are autonomous prescribers. They perhaps undertaken accredited courses in heart failure, so they've got a really complex and robust understanding. And then we've got a lot of newly qualified nurses coming into general practice who are trying to consolidate their student experience. And so it feels like a huge learning curve for those newly qualified nurses to learn about a disease that's very complex and multifaceted. So I think it's understanding different roles, understanding who your local heart failure nurse specialist may be in your locality, and then for the local heart failure nurse specialist to understand the role of the general practice nurse, which is from public health right through to palliative care and everybody in between. Yeah. So as I say, it's important to create, I think, for patients that time and that headspace to discuss how they're feeling. And often I think joint clinics or group consultation is the best way forward, really, in that arena.
Okay, lovely. Thank you, Louise. So I think we've got a minute left. So thank you, everyone, for contributing to that. There was some lovely insights there. And Delith, shall I hand back over to your good self?
Lovely. Thank you, Edith. So we've heard this evening about the different projects going on around the UK, Detectors Undetected. It is about making every contact count and working together collaboratively. And hearing about different services and how they're working gives us all ideas on how we can look at our own services, our own localities and our own areas to see if we can link up with other services and work together in a different way, new ideas. I think the key take-home messages are for us all to recognise the symptoms of heart failure, so fluid build-up, fatigue, and fighting for breath. And if someone presents to your clinic, hospital, or GP surgery, it's about considering taking an NT-proBNP blood test, because the earlier heart failure is detected and treated, the better outcomes and quality of life for the patient. So I'd like to take this opportunity to thank you all for taking the time to present to us the excellent initiatives and work going on in your areas, and to you all for watching this evening. Thank you.